It's a very new, and we look forward to get the result after finish the study. It's very interesting. Thank you for your presentation.
Thank you very much. So now we move to the next presentation, which is experience with FRED on FREDX flow diverting stent by Dr. Peter James Muse from UK, please.
Thank you, Professor. I've been given the very tough job of following a presentation by Professor Pirot, but I'll do my best. Continuing a theme, talking about flow diverters and surface modification of flow diverters. So I'm Peter Muse. I'm a neurosurgeon and neurointerventionist from Australia, and I've been asked to come and speak about international experience with FRED and also the newer version FREDX, and discuss the importance of surface modification for flow diverters. Thank you to the committee for inviting me. I'll begin with some revision for any residents and fellows in the room so the trained physicians can have a rest for the first half of the talk, and then we'll talk about some surface modification. These are my disclosures. So early work to explore the feasibility of vascular reconstruction using flow diverters began in the first part of the 21st century and was spurred on by a need to address the poor obliteration rates and the high recurrence rates from existing endovascular techniques for aneurysm treatment at that time. There was also obviously a desire to expand the indications for treating wide-necked and fusiform aneurysms, and this work culminated in the release of the first commercially available flow diverter, which was the pipeline embolization device in 2007, followed over subsequent years by a number of other devices, including the FRED by Microvention in 2012. Now, the therapeutic effect of flow diversion can be considered in three different phases. There's the initial hemodynamic phase, followed by thrombus formation in the sac of the aneurysm, and then subsequently by vessel wall remodeling with endothelialization. The hemodynamic effect begins as soon as the device is deployed, with intra-aneurysmal flow reduced by as much as 98% when compared to an unstented aneurysm due to impedance across the neck of the aneurysm posed by the metal of the stent. The effect on the any jailed branches is not as profound as that, however, provided the stent coverage, so the metal coverage of the ostium of the branch is less than 50%, and that's thought to be due to the persistent pressure gradient across the stent for a perforator, which doesn't apply to the aneurysm. So early experimental studies reveal that the ideal combination for rapid and stable aneurysm occlusion whilst maintaining patency of any covered side branches can be achieved with a maximum porosity of 70%, but a minimum pore density of 18 pores per square millimetre. Other combinations of both porosity and pore density can lead to stable aneurysm treatment, but often at increased time frame. Note that both the pore density and the porosity of the stent are only partially designed in features of the stent, and there is considerable ability to vary that by stent sizing selection and the interaction between the stent, the vessel wall, and the aneurysm neck at the time of deployment. However, it must be noted that there is a minimum amount of metal surface coverage that is required to achieve flow diversion, and any less metal coverage than that will not result in meaningful flow diversion. Now we know, courtesy of the work of Rudolf Virchow, that the seeds for thrombus formation are sown by the combination of alterations in the flow of blood, abnormalities in the vessel wall, and abnormalities in the constitution of the blood. And so we can instantly see that with flow diversion that the conditions are met for thrombus formation, both in the aneurysm sac, which is what we want, but also in the lumen. Now, very rapidly, clinical validation of the principles of flow diversion came after the release of the pipeline device in Europe and the US, and many registries and studies demonstrated rates of adequate aneurysm occlusion of over 73% beyond 6 months. However, they also demonstrated that hemorrhagic and ischemic rates were moderately high due to both the highly thrombogenic surface of the amount of metal in the wall of these stents and also the effect of the anti-aggregant medications required to manage that thrombotic effect. And so it was apparent that whilst these first generation flow diverters were highly effective, both published and real-world complication rates were moderately high. Now, the flow redirecting endoluminal device, called FRED to its friends, came to market after receiving the CE mark in 2012, and I'm pretty sure it was first available in Australia and the Asia Pacific region in 2015. Now, it was specifically designed to address some of the limitations of the earlier devices. It's a dual-layered stent constructed of nitinol, and it's a self-expanding stent. The outer stent, which is comprised of 16 wires, is designed to serve as a scaffold to increase wall apposition without sacrificing navigability, particularly in the setting of tortuous vessels. The inner low porosity stent, which is 3 millimeters shorter than the outer stent, is the one that achieves the flow diversion, and the two layers are woven together by two tantalum wires to increase visibility. As I said, the nitinol construction with its shape memory facilitates trackability. The dual layered design allows outer stent, which acts as a stable scaffold to overcome the innate reduced radial force inherent in a flow diverted design and increase wall apposition. The first large published series documenting efficacy and safety for FRED was the European FRED study, which took the form of a post-market registry publishing 579 aneurysms in 531 patients and was published in 2018. And pleasingly, the efficacy outcomes were similar to those that had previously been reported for other flow diverters, with an 82.5% aneurysm occlusion rate, including, of course, both complete aneurysm occlusion and a neck remnant at 6 months. Less pleasingly, device-related thrombosis was also similar to that previously reported for other devices. Now, this wasn't actually directly published, but could be inferred from the published combined rate of ischemic stroke, vessel stenosis, and vessel occlusion. Similar results were subsequently reported by the French SAFE study and also the pivotal US study most recently published. Now, success in the application of flow diverters in the original indications led to expanding indications, including a desire to utilize these devices in more distal circulations to treat anterior communicating localization aneurysms, distal anterior cerebral and middle cerebral artery aneurysms. However, there are significant challenges in using the original large devices in these smaller vessels. Navigability is a problem. Getting these large, stiff devices to these peripheral circulations is challenging, and there's often an increased complication rate from the stiffness of these devices being deployed or being delivered to less supported peripheral circulations. Unfortunately, the efficacy was also not there to reward the efforts of the practitioners, and that's probably due to the alterations in middle surface area porosity and pore density that comes from deploying an oversized device in a small vessel. And so FRED Junior was the first device specifically designed to address some of these limitations and allow flow diversion in smaller diameter, more peripheral circulations. And what they've done, what Microvention have done with FRED Junior is they've reduced the number of wires in the inner flow diverting segment to maintain the porosity, the middle surface area coverage, and the pore density in the smaller diameters, but they've also modified the delivery system with a shorter wire to decrease the probability of wire trauma in peripheral circulations. And again, it's had published success rates not dissimilar to its bigger brother, for example, in that study in 2017 by Molenbroek. Now, when it comes to flow diversion, it's easy to see that thrombus formation is both our enemy and our friend. The therapeutic effect of flow diversion relies on thrombus formation in the sac of the aneurysm. But unfortunately, due to the large middle surface area that's required to achieve that flow diversion, we also sow the seeds for intraluminal thrombosis. And so we know that in-stent thrombosis, stent stenosis, and even vessel occlusion are the consequences from this high middle surface area. And we know that ischemic stroke is the largest single cause of both long-term morbidity and mortality in most published series involving most flow diverter types. And so as a consequence, the next area in flow diversion development is focused on modifying the surface of the devices, trying to address one of Virchow's triad to reduce the propensity for thrombus formation in the vessel lumen, but without sacrificing any of the device's mechanical features that contribute to such spectacular success in causing aneurysm, thrombosis, and remodeling. Now, the ideal surface modification would significantly reduce the thrombogenicity of the device, but not affect the performance of aneurysm occlusion. Furthermore, it would be at least as effective as any unmodified stent, or hopefully more effective in promoting endothelial growth and coverage, as ultimately it's endothelialization that leads to the aneurysm stability and also reduces the propensity for late in-stent thrombosis or thrombotic complications. And just as an example, late stenosis or late thrombosis occurred in 2% of patients in the SAFE study, just as an example. Now, we've learned a few lessons from the cardiology literature. It was very clear that early generation drug-eluting coronary stents were highly effective at inhibiting smooth muscle cell proliferation and coronary restenosis post-stenting. However, unfortunately, they also prevented endothelialization, and this had the undesired consequences of increased late vessel thrombosis and also requiring the duration of dual antiplatelet therapy required. And so we can see that a surface modification that would reduce thrombogenicity alone but has an adverse effect on endothelialization may actually be a more harmful development rather than a positive one. It might be a backwards rather than a forward step. And so a number of approaches to surface modification have been devised and brought to the market to either reduce thrombogenicity, increase endothelial cell adhesion, or both, as alluded to by my previous speaker. Now, Microvention, for what it's worth, have leveraged their partnership with Terumo, who have over 30 years of HEMA-compatible surface modification with PMEA, which is poly-2-methoxyethyl acrylate. And this was initially applied to extracorporeal circuits in the space of the cardiothoracic surgery and intensive care arena. More recently, with short-term implants in the realm of medical oncology. And more recently, this technology, called X technology, has been applied to permanently implanted neurovascular stents. It's been known for some time that PMEA, the poly-2-methoxyethyl acrylate, has highly HEMA-compatible properties that were not shown by other polymers. More recently, the mechanisms for foreign body thrombus formation have been understood. The key to the HEMA-compatibility of PMEA is its controlled hydrophilicity, which is the effect that this has on the boundary water layer, and then the secondary effect that this has on protein adsorption and then subsequently platelet aggregation. It's recognized that foreign bodies, once they're exposed to blood, rapidly lead to non-specific plasma protein adsorption, but also to conformational change in those adsorbed proteins, which makes them more of a target for platelet aggregation and platelet activation, and subsequently thrombus formation. And unlike untreated stents or other polymer coatings, PMEA has a low protein adsorption rate and also a low denaturation rate, which leads to a low rate of platelet aggregation. And so with FREDX, this X technology, which is derived from PMEA, is covalently bound to the nitinol of the stent. Yoshizawa published recently in JNIS about the in vitro effectiveness of the X technology by comparing conventional FRED without a coating, FRED with the X technology, the FREDX, and also pipeline with a shield coating in blood loops using blood donated from healthy volunteers. A control loop was one that didn't have any device in it, and all loops were coated themselves with PMEA to exclude any confounding results from the loops themselves. Now, after exposing the implanted devices to the blood, the devices were removed and subjected to electron microscopy, where it can be clearly seen that the uncoated FRED had visible thrombus formation, whereas neither the FREDX with the X technology or the shield-coated pipeline flex had significant thrombus formation. Furthermore, the blood that was in those same loops was assayed for platelet count, beta thromboglobulin as an index of platelet activation, and also thrombin-antithrombin complex to assess the rate of coagulant protein consumption as a secondary index of thrombus formation. Again, the bare metal stent did worse, with more platelet aggregation, so that's seen as platelet depletion in the blood, as well as significantly increased rates of beta thromboglobulin and TAT, indicative of thrombus formation. And so this basically confirms what was already known, that the X technology is just as hemocompatible when applied to intravascular stents as PMEA had shown us over the last 30 years in other applications, and leads to a significant reduction in material thrombogenicity. But what about that second characteristic of the ideal surface modification, the lack of inhibition of endothelial migration and adhesion? Endothelialization of the stent is what ultimately leads to stability of aneurysm occlusion and also decreases late thrombus formation, and is what allows us to cease anti-aggregant medications. Now, it's previously been questioned that maybe phosphorylcholine polymers might inhibit endothelial adhesion in vitro, although animal studies would suggest otherwise. In the same paper, Yoshizawa studied endothelial adhesion using the X technology by using cultured endothelial cells on both nitinol and PET sheets, both bare, coated with the X technology, and also coated with phosphorylcholine. And it was clear that the X technology coated sheets, as well as the bare sheets, had similar endothelial adhesion, whereas the phosphorylcholine sheets had significantly reduced adhesion, but also the endothelial cells had this sort of rolled up ball morphology. But again, the authors acknowledged this in vitro study might not transfer to animal models or the clinical application. Now, in vivo studies using implants placed in rabbit aorta have shown that there is no significant difference in endothelialization when you compare the uncoated FRED stent with the FREDX at either 30 or 90 days. And similarly, a rabbit elastase model has demonstrated no significant difference in either radiographic or histologic aneurysm exclusion or the rate of intimal formation in either 30 or 90 days between FRED and FREDX. Now, it has to be acknowledged that similar data exists for all the other surface modification techniques that are currently available or coming to the market. It's also widely recognized that in vitro and animal models do not necessarily translate accurately to clinical applications. For all devices, however, clinical data is currently lacking, as they're all relatively new to the market. FRESH, published in this month's American Journal of Neuroradiology, is a large series published out of a European retrospective international cohort study, which includes 161 patients all treated with the FREDX with a median of 7 months of follow-up. And this demonstrated an acceptable 66% rate of aneurysm occlusion, which is comparable to earlier studies with FRED, but also an early thrombogenic complication rate of 4.3%, which represents about a 50% reduction when compared to historical studies. Now, there are problems with FRESH. It's got limitations. The stent selection, the stent application was very heterogeneous, as was follow-up in both duration and follow-up modality. It's a self-adjudicated, self-reported study, and so it's inherently subject to both reporting and publication bias. Now, the authors acknowledge this, but they also acknowledge this as a real-world, pragmatic publication, and at the very least, it gives us some indication that FREDX is not inferior to its predecessor, and also it gives us some support to the notion that hopefully the reduced thrombogenicity will be borne out in future clinical studies. And so in summary, I'd like to say that FREDX is the latest generation of flow diverter from microvention, which builds on the principles that are well established for flow diversion that were already apparent in predecessors FRED and FRED Junior. It also draws on extensive experience of PMEA hemocompatibility research and surface modification, which has now evolved into the X technology. In vitro and animal studies and early clinical experience suggests comparable efficacy, but also reduced thrombogenicity when compared to the predecessors. But of course, more studies will be required to demonstrate how this bears out in the long term.